Welcome to Patients at Risk, a discussion of the dangers that patients face when physicians are replaced with non-physician practitioners. I'm your host and the co-author of the book Patients at Risk, The Rise of the Nurse Practitioner and Physician Assistant in Healthcare, Dr. Rebecca Bernard. Nurse practitioner and physician assistant advocates often reassure physicians that they face little liability or risk when performing supervision. They usually insist that nurse practitioners and PAs are liable for their own errors. But case law demonstrates that this is false because if state law requires physician supervision or collaboration, then the physician may be held vicariously liable in the event of negligence, even if the physician was never consulted by the non-physician practitioner about the patient's care. And today we're talking about two physicians who experienced negative repercussions from this exact scenario when errors were made by non-physicians that they were required to supervise. Today we're meeting with Nancy Burley. She's a family physician, and Shenary Cotter. She's also a family physician. Welcome both of you to the show. Well, Dr. Burley, tell us about your scenario and how you got into problems because of the vicarious liability or supervision of a nurse practitioner.
The nurse practitioner that was in our office at the time was one that we had handpicked. We had worked with her as a nurse and we knew where she had done her training. She had done her training in person. And we thought that if we were going to have a nurse practitioner, that was the way to go, was somebody who we knew, who we trusted. And I don't even know if in the end it came down to her care specifically. So there were three of us and three physicians in the office, and one of us, not me, had agreed to be her supervisor of record. However, we weren't all there together every day. We were each part-time. So there was one day a week that I was alone in the office. And so when I was alone in the office, I was the one that the nurse practitioner would come to. She came to talk to me about a pretty innocuous sounding case. And we talked about it briefly, and then she left. And I didn't know, but apparently that particular patient came back and saw the nurse practitioner again with the colleague whose patient it was. Our nurse practitioner didn't have her own panel. She only saw our patients. And then that physician signed off on it. She then also subsequently had two ER visits, one sort of in between our office visits and one after, and ultimately had a poor outcome. And so the family sued, and I found out that I was named because I had signed off on that chart on the first visit.
Now, when you look back and you see everything, did you have any clue, or do you feel like you got all the information, or could anything had been done differently that could have changed the outcome, do you think?
I am not sure if anything could have been done differently at our visit. In the end, the case was settled, and I was found to have no part in the settlement because their expert witnesses felt that nothing that happened at that visit played a role in what happened eventually. But I do wonder what it would have been like had I seen the patient, had I gotten history, had I actually laid eyes on the patient versus getting it secondhand from a nurse practitioner, even one that I trusted. But I also was in the middle of a busy day. Like, it wasn't that I was sitting in my office, just supervising a nurse practitioner. I probably, was back to back with patients and did this in between.
Well, I think that's one of the things that's interesting when we look at this landmark case of Denter, who was the hospitalist who received a report from a nurse practitioner by telephone about a patient. Ultimately, the patient had a very bad outcome, and he was sued because he did not recommend that the patient be hospitalized. But there's some dispute between him and the nurse practitioner as far as what information was given. And the question is, did the nurse practitioner give the appropriate information that helped the doctor make the right or wrong judgment? And I think that is what it comes down to, is unless you're examining or talking to the patient yourself, you're relying on someone else's information, and that may or may not be complete.
Correct. And because nurse practitioners, their training is different, they may or may not get the same information or the same examination as we physicians would.
Dr. Cotter, tell your story about what your scenario was.
Well, actually, in my career, I've been practicing medicine since '97. I've had two lawsuits, and both were associated with nurse practitioners, one of which I was supervising And that one was thrown out because I was working, essentially, it was going to be a case of sovereign immunity, so they didn't pursue it. The second one was a nurse practitioner that I was not the supervising physician on record. He was actually employed by a nurse practitioner staffing company that placed him in the nursing home. An excellent nurse practitioner. I'd actually worked with him for a long time, but in the nursing home, I had a stable patient that I did once every 30-day visits on. And in between my visits, he on Coumadin with no indication. So I had no way of knowing he had done this, of course. And then one night I got a call stating that they had been calling the nurse practitioner for the patient having a headache. And so I said, you need to send this patient to the emergency room with, severe onset of an unexplained headache, not responding to these medications, where she was found to have an INR that was unreadable. While waiting in the ER for the inpatient service to admit her, where they were going to try to reverse her INR, she actually had a massive intracranial hemorrhage. She spent 2 years in the intensive care unit, and they brought a suit against me and the nurse practitioner for wrongful death. So this was not a nurse practitioner I was supervising. This was an association. The company he'd been working for was actually shut down by the FBI. And so he lost his malpractice insurance, which handily caused him to be dropped from the case. And because of the lien that was presented by the hospital, my malpractice attorney said, what they're going to hear is that the family owes all this money and they're going to want to give some money. You need to settle. And so they settled at $20,000 under my policy limits. So now I have a wrongful death suit, which for physicians, those don't go away. They last forever. They're on your record forever. And so just even hearing, Dr. Burley's story and talking about this today, there's a lot of trauma associated with this whole thing. Even though it happened 14 years ago, it still brings up a lot of trauma.
You didn't even have knowledge of the prescription for the Coumadin. You just get a call saying this patient has a severe headache. You say, please send them to the ER. And then ultimately you're found, or you have to pay, or your malpractice has to pay for something that you had absolutely nothing to do with, no knowledge of, and that follows you.
Exactly. What's worse about the situation now is that with the pursuit of independent practice, to my knowledge, no legislation has increased liability or responsibility in any state. And the AANP has not pursued getting it. So when they go and say we would like more, independent privilege, we do not want, equal responsibility. And so the physicians are being left in this position now where if I'm seeing a patient even in my office who's getting care from a nurse practitioner in the community, they do aesthetics, they do IV infusions, they do joint injections with PRP. I mean, they've set up all these little practices where they do whatever they want to do, basically. I'm actually responsible for everything about that care that my patient is getting from somebody that I have no association with.
Wow, that really gives me chills because, like you mentioned, when you talk to lawyers, it's very interesting because they have this totally different perspective. They're like, oh yeah, you pay some money, it's a claim, it's a suit, it's
not personal. That's what they told me. It's not personal.
They do not see it as personal. They see adversarial relationships as just adversarial in that setting, and then somehow they're able to disconnect. And we can't do that because I think we still care about our patients. We don't want them to be harmed. And it is personal because we do take a lot on ourselves.
Well, I mean, having to have your personal assets in tenants by joint entirety is personal. I mean, this affects our lives. This is not impersonal. And then caring about a patient and having somebody tell you that's what they basically said was that I killed my patient. I mean, it doesn't get more personal than that.
You didn't, but you can't really defend yourself because there's just this thing out there on the internet or wherever else, and you really can't defend yourself. Dr. Burley, how was your emotional state in dealing with all of this?
It was definitely rough because, there is some trauma associated with it. I mean, I still went through a deposition. I still, was preparing for trial. I was dealing with lawyer visits, while trying to maintain a practice and also have a family and a life. And like I said, this does travel with me. I'm currently working in telemedicine. And so every time I apply for a state license, this comes up.
Dr. Cotter, what advice would you give physicians listening that may be asked to supervise or work with non-physician practitioners in light of your experience?
It would have to be a very, very specific and controlled situation. Both of us, Dr. Burley and I were working with nurse practitioners that were good nurse practitioners, but they're not physicians. And you're really relying on somebody that has so much less training and experience, and apprenticeship training is what makes doctors. That's what makes us different. So I think you have to be really able to be available and hands-on. And so I would say if the nurse practitioner could go in and see my patient, and then I could come in briefly at the end and the nurse practitioner could present, I can lay my own eyeballs on the patient, lay the hands, which are the tools of my trade, on my patient, then I would be comfortable in that situation, or in a situation where I had designed specific protocols. Like, for example, if I worked in an office where I wanted a nurse practitioner to see my acute patients or to manage phone calls, and we would have a very specific set of protocols that nurse practitioner would follow of what patients she would see or he would see and how each thing would be handled. I think that would be the situation that I would need to have.
Yeah, I agree. I mean, for me, even just having them see acute patients, I'm worried about, unless I know it's something that seems so low acuity. For me, I would say maybe if I had a chronic patient for a follow-up of something that I just wanted them to check in or maybe do some education. And then if anything was different, I need to be involved. I mean, but then you ask yourself, like, how is that really helping me be more efficient in seeing patients? There's a role, but I agree with you from a liability perspective, it seems pretty limited. What about you, Dr. Burley? What advice would you give physicians who might be supervising?
Yeah, I think that Dr. Cotter makes some really good points. Personally, I don't see a place where I could ever supervise a nurse practitioner again. One of the other thing too is, just so you know, the chief complaint on the patient this case was headache, which is one of those pretty low acuity sick visits that, unless you have very highly trained staff, they're not going to know what to put in with your nurse practitioner and what to put in with you. And so that it's to me, I think, yes, very controlled circumstances, but really I won't do it. My telehealth company that is primarily doctors is going to start employing nurse practitioners. And I've been very clear that I will not supervise. They are planning to only have them in states where they don't need supervision. But again, you have to remember that physicians can be called, like it becomes a matter of who touched the chart.
Yeah.
Right. So if I saw a patient and then they saw a patient, I could still be called anyway. I don't know how different it is from my physician colleagues, except that at least the training with my physician colleagues is the same as mine. So I just think we have to be very, very careful of what we sign in on. I often see these things where, what do you think? I'm being offered this amount of money to and I'm like, please don't.
Yeah, don't do it unless you really fully understand what the potential outcomes could be. When I hear chief complaint of headache, I get scared because there's, tension, headache, and stress, and, sinus, and then there's, intracranial bleed. It's like when I hear dizziness. I mean, these are what I no, this is, to me, not something that I would feel comfortable unless it was a follow-up chronic migraine doing well, maybe that. But you make such a good point in that you don't even necessarily have to be actively supervising to still be implicated. And I think the lesson here is that you have to personally speak to and examine patients really all the time to ensure that you're going to be able to at least have the best chance of not getting into trouble through somebody else's work.
Totally.
Yeah. And I would say that the fact that that one visit became is shocking, even to this day. So I guess the other piece to all of this is the thought of the legal system and what we have become in this country. In my case, actually, I believe that the nurse practitioner actually had the exact same malpractice amounts as we did. And so I think the lawyers were really just trying to get as deep as they could into the pockets. And I'm not trying to, say anything about lawyers. I mean, I think they have a job to do as well, but, they could take from each of us.
So one of the ideas that I've come up with for my practice, we thought about instituting and have not yet had need, is a disclaimer or release of liability stating that a patient acknowledges that any care that they receive from a nurse practitioner outside of our office or any practitioner or clinician other than an MD, they release us from liability for any outcome of that. For that same exact reason, Dr. Burley.
That is such an interesting idea. I think that's something that we might want to get with our attorney colleagues and ask them about something like that, and our malpractice insurers, and ask them about that too, because I think that there needs to be pressure on malpractice companies to have premium parity, because we know right now that you can get malpractice insurance as a nurse practitioner far less expensive than as a physician, because historically there have been lower rates of malpractice and for some of the reasons that we've talked about. So I think that's a very innovative and interesting idea, Dr. Cotter.
Well, I would actually be curious, Dr. Cotter, what is your malpractice like now? Because my colleague, who also it was settled, and part of the settlement was related to her. She pays a very high premium for her malpractice. And I think that's another thing to consider too in the long run, what this does for you, for your malpractice moving forward.
It went up. I was in private practice, so it went up for many years. And then it finally gradually went back down. Like I said, I think this was 14 years ago. Okay. So now I'm in direct primary care and my premiums are actually very low. I'm also married to an OBGYN, however, who is one of the most frequently sued types of physicians, and his malpractice has varied. It's been as high as $33,000 a year due to being in the state of Florida and what a malpractice suit does to your license. And yeah.
Well, I want to thank you guys both so much for joining me. If you'd like to learn more about this topic, I encourage you to get the book. It's called Patients at Risk, The Rise of the Nurse Practitioner and Physician in Healthcare. And if you're a physician, please join our group. It's called Physicians for Patient Protection. Our website is physiciansforpatientprotection.org. Thanks so much. We'll see you on the next podcast.